Hello, hi everybody. Bear with me 1 second while oh, where are you? Too many tabs. So I have presentation which is up, and then I also have my laptop for some notes just in case. But all right, bear with me 2 seconds. So just for a little bit of context, I live with ME myself, and I get a lot of brain fog, and life has thrown me quite a lot of curveballs recently. And so if I'm a little bit vague or a little bit not quite on the ball, please bear with me because if you have ME or any kind of brain fog, you get it. So just a quick, I do have a little introduction slide, but I am Tanya. I am another osteopath in Canberra, who treats a lot of people with complex health and pain issues. Um, I'm quite often the practitioner people end up with when they've tried lots of other people, similar to Steph, where we end up with a whole lot of stuff, and then we try and pick it all apart to get some quality of life back. So that is my jam. Before I begin, wait, wrong computer. This is going to happen a lot. There we go. So before we begin, I'd really like to begin by acknowledging the Ngunnawal people and traditional custodians of the land on which we're meeting today. This is a Canberra group, so I'm assuming everyone's in Canberra, but as well as other people with connections to the land of ACT and the surrounding region. I also want to acknowledge that sovereignty was never ceded and it always was and always will be Aboriginal land. So here is me. So a quick little update. So I run my own business. I'm a disabled business owner, and I found that I need to work for myself in order to be able to practice because I love it. I last year became a registered Perrin practitioner, which is a form of treatment for chronic fatigue syndrome from an osteopathic perspective. I'm also queer and non-binary. And I have a list. This isn't even the comprehensive list, but my lived experience with ME, ADHD, likely autism as well, POTS, hypermobility, as well as complex chronic pain, which includes migraines. For fun, I do pottery and Pilates. My Pilates does not look like the normal classes. It is very basic. Um, and so I have a few things that I will always repeat, and I haven't put them through, but one of my pet peeves is when people come in and they just keep telling me, like, I'm trying, and I'm not being believed. And to be honest, in clinic, I've never seen a patient with chronic illness that has not tried their hardest and beyond what their capacity is. So I'm going to keep referring back to Steph, but like we work and have a very similar ethos in that space. So today, and please put hands up in Zoom. Please put your hand up or just, yeah. If I'm going too fast, because I'm realizing I'm talking very quickly, or if you have any questions throughout, you're welcome to ask, but I have also put questions at the end if you have any, or you're also welcome to ask Steph if you want anonymity as well. So today we'll do a little bit of an introduction to ME and an overview of that, as well as that kind of mainstream diagnostic criteria and what ME can look like. Then we're going to go into the Perrin Technique. So this is very specific. It has its own assessment and diagnostics, as well as treatment and self-management. And then at the end, we're going to look at co-occurring conditions, and the list is not even comprehensive. Because I'm trying to jam pack so much in, it may be more of an overview of every bits and pieces rather than in depth. And if I go, Steph, if I start going too in depth into the science because I love it, please let me know. Yeah. Because I try not to, but the science is very cool. But we also don't have time for all the science. So ME, which my brain can never remember. I'm going to refer to it as ME because my brain cannot remember. What is it? Myalgic encephalomyelitis. I usually get to myalgic encepha and then my brain goes, what's the rest? So it'll be ME, and I prefer the term ME as well, which a lot of patients do because it is more of a medical term And so when you're in a medical environment and clinical, it is taken a little bit more seriously than chronic fatigue syndrome, which just really gives the impression you're fatigued a lot all the time. It's definitely not wrong, but it's definitely not wrong. But it also means that like the clinical outcomes and the considerations tend to be minimized, which they shouldn't be because people can die of ME. So ME, it's complex, it is highly disabling, it is a neurological disorder. In Australia, it was often seen as a psychological disorder. So I know as myself as a teen, I was labeled lazy, depressed. It was floated, and then it ended, it was basically seen that, well, I just need psychological care. At the end of the day, the talk therapies are part of it, but it's not going to fix it. And so thankfully, the World Health Organization has now made it that it is a neurological disorder. It's also affects like muscles, joints, digestive, immune systems, your cardiac system, metabolic systems isn't in there because I took this from the Emerge Australia, but metabolic is also part of that. So that's our energy, it's our body processing and creating energy, which it doesn't do enough of quite often. This is a really long list. It will With ME, it will overlap a lot with the co-occurring conditions, which I probably should have put after this, so I apologize. But there are some really key ones that come into the diagnostic criteria, but the really strong key one is post-exertional malaise. So I've got a slide for that next because it gets its own slide. However, when we're talking about the Perrin technique, and I'll probably come back to this because I like to repeat things for very obvious reasons because it helps you to remember, myself remember. But a lot of the things that we look at is sleep disturbances. So when we're looking at sleep disturbances, it's not just insomnia, it's also hypersomnia, so getting too much sleep. Vivid dreams are a really big part of it. And then one of the big ones is waking up unrefreshed. And Steph and I were talking about that waking up unrefreshed, some people you'll have days where you're like, oh, I feel refreshed. But if you compare that to a healthy individual, you're probably still unrefreshed, unfortunately. The cognitive issues are massive. And this is one that time and time again, when we look at like the fatigue and the PEM, then the next one is always the brain fog. It's the short-term memory. It's not being able to read for long periods. It's difficulty concentrating. And so trying to work, trying to do tasks around the house becomes really challenging. We also, key ones are like your gastrointestinal. So I'm just expanding on ones predominantly that aren't just straight up. But again, that crossover of food sensitivities, IBS, pain, bloating, alternating between constipation and diarrhea. It's a whole lot of fun, and it's not fun to talk about with your health professional. So this is something I try to normalize. We talk about pooping, we talk about peeing, we talk about all of the things because we don't, our whole body is impacted by this condition and by hypermobility if you have that, and which this is a hypermobility group. So connective tissue plus ME, it's a whole lot of fun in there. The other one is like the inability to temperature control, and it gets all really dysregulated. So then you've got these cold extremities. Um, and then malaise. Malaise is the fun one. So you get that after with the post-exertional, but you can just get it as part. So it's those cold and flu symptoms. It is quite often we'll have a regular sore throat, which in the world of COVID becomes really challenging because you're like, am I getting sick? Am I actually, or am I just flared up? You're not just flared up. Sorry. And then the other one, the one I really want to talk about is depression, because too often you see, oh, you're tired, you're stressed, you're depressed. And depression can actually, and this is in another slide, be a cause for ME. It can actually be a predisposing factor. But quite often what we see is the secondary depression, which is you've lost the joy, you've lost your capacity to engage with your life, with your social. And so, of course, you're going to be depressed. I'm trying not to swear. Because, like, so when I'm looking at that symptom, it's as a secondary. That's not to say that they can coexist as a primary as well as ME, but wanting to make that distinction because too often you're framed as being depressed and that's your problem, when in fact you have ME with depression. So I keep using the wrong computer for this. Okay, so now we have post-exertional malaise, which is one of the biggest conversations I have with patients because I will have a lot of people come in with chronic illness who don't feel like they're tired enough to have chronic fatigue syndrome or ME. They don't have PEM, but they've adjusted their whole life and to avoid PEM. And so, and I am one of those people. So it wasn't until I did the course, the Perrin course, that I realized I've definitely had ME since I was a teenager, which is now 20 years that I've somehow done a dance degree, an osteo degree, and I've worked part-time now, let's put it that way. So when we're talking about PEM, it's a key defining symptom of ME. We're also seeing it in long COVID, which acts similar to ME. We're not talking about that today, but it will just pop up because it is relevant. So PEM is the worsening of symptoms, and it's not just it's a result of not just physical exertion, it's mental, emotional, and for people with sensory issues, which again, co-occurring quite often, it is that overload and exertion. And exertion doesn't look like I've done a massive exam or I've run up a hill. Exertion can be as simple as I read 2 chapters of a book, or I watched a 3 hour long movie because for whatever reason they like to make 3 hour movies now without a break. India does it well. They put a little break in the middle, an intermission. But it's not so quite often people come in and they're like, oh, but I can't run up a hill. And I'm like, but if you tried, would you crash? Yes. Do you crash after a 10-minute walk? Yes. So, and that crash isn't always like immediately. Sometimes when you push hard enough, it will be, but it can take up to 3 days. So trying to connect the dots back can be a challenge because you're like 3 days later, you're like, what did I do yesterday? And you're like, I didn't do anything. And then you have a lovely practitioner come in and go, what were you doing at the beginning of the week? What were you doing last week? And then you're like, oh, yeah. And I do that to myself all the time. So, and then also that crash doesn't always just look like I'm stuck in bed and I can't function. It can look like my tolerance for sensory issues, and I'm going to use an example from one of my lovely patients who did way more than she should have, and then was like, oh no, it was fine until we talked about it. And she had to change the sheets of her bed because the sheets didn't feel right. And then the sound of the quilt crumpling was too much and it made her and so she ended up having a full sensory overload and meltdown. And that was a product, that's not her norm, and it can be, but that was a product of overloading and that PEM, and then all of a sudden the sensory issues are exacerbated. So it's not just ending up in bed and being tired. You can also end up with that malaise, so the sore throat, feeling like you're getting sick, but you're not quite getting sick and it doesn't quite tip over to, full-on sinuses, but you've got a little bit of congestion, you've got a little bit of stuff. That can last days, so a day or two, to weeks, to months. And then when we start seeing the weeks to months, we start seeing a shift in your baseline. So you don't, each time there's so for me, it was long COVID 3 times. My baseline reduces each time. And then it's like trying to get it back to that baseline before. So that's one of the things that's really important with when we're talking about post-exertional malaise. It can, when you push it too far and you stay in that and you keep pushing, it can reduce that baseline. But there are ways to manage that. So that we'll touch on that, but that can be part of another discussion if we need to. And as I said, people adjust their lives. So I have I'm going to use a couple of my patients because none of you know who they are, who was like, I don't get PEM. And I'm like, what happens when you don't go to bed at 7:30? And they're like, I don't function the next day. And I don't function for multiple days. And I'm like, great. You have created a routine that supports your capacity, which is fantastic and is one of the key things to do, but it also doesn't mean that PEM doesn't exist. So I'm really mindful of time because I can talk about this forever. How long was I supposed to go for? I didn't even ask you that question.
Whatever you want to do, they usually have about 30 minutes.
Okay, we're going to go more for the 40. Triggers. So this is super multifactorial. It is not just one thing. However, what quite often will happen is there will be a sequence of events. And most often there is that predisposition of the nervous system getting super, super ramped up. And then the one I see the most at the moment is glandular fever as a teenager or in their 20s. And then nothing's ever quite the same again. And it's like there's like that reminiscing to pre-glandular fever. There are multiple viruses that can do this, but there's also other factors like my brain is like, how do I say immunologic? Oh my God. Yeah, I'm recording this too.
Immunologic. No, I
Immunological. So this is looking at your immune system and it's not functioning quite as well as it should. And so that's where other conditions can come in, like our autoimmune conditions. And it doesn't mean that it causes ME specifically, but when you start creating a map of different things, you start seeing a pattern. And quite often, and like part of what I do is we go through from childhood to now and we look at that picture. And that picture can include things like being a prem baby, growing up in a house with a bit of mold, because that was a thing, at least when I was a kid. Like it wasn't thought about too much. It was like, oh, there's a bit of rising damp. That's okay. And then all of a sudden you got these allergies. And anyway, this is my tangent. So then we have like hormonal imbalances. So I haven't got a statistic page, so we're going to kind of get that now. AFAB in females are about a 3 to 4 to 1 ratio to males. So we're looking at quite significant with females or AFAB. And so with that, a big part of that is the hormonal picture. And especially once we hit the teens and we're getting that estrogen, progesterone roller coaster, that starts giving a little bit of predisposition and can impact all of our systems. On top of that, and this is a little bit of the science, is there's 2 other factors, which I'm going to tell you now. Leptin hormone, which is our hunger hormone, is higher in women or AFAB. And so that can oh my gosh, thank you. This is why I did the disclaimer. Also, one of the symptoms I didn't put in that I have never understood why is there'll be times, so with the leptin, it can influence with loss of appetite, no appetite at all the way to no satiation. So you eat and you don't feel satisfied and you keep eating and you keep eating and you keep eating. And it's different from when you're eating a tub of ice cream because you're sad or depressed. I just keep eating because I just feel like I need to eat, and like almost like you're like, I just want to get some energy. I just need energy into my body. That is a symptom of ME, it turns out. And part of that is because of this dysfunction of leptin, and you can have too much, not enough. And so you get this kind of roller coaster. And then the last one is, we'll talk about lymphatics shortly, is that generally speaking, females in AFAB have breast tissue, and it is our largest lymphatic tissue. And so when that all gets congested, and I still am trying to figure out a term, not toxins, because it's not a great term, but we get a buildup. And so when the lymphatic system's not working, and because breast tissue, larger chest tissue, it will unfortunately add to that picture. So just a little fun fact. And then the other thing that's really important to note is quite often we do see ME post tick bites. However, because of Lyme disease, it needs to be ruled out prior to a diagnosis. So I have a patient at the moment that had a tick bite, and Lyme disease has been ruled out. And so we're looking at other factors. Okay, diagnostic criteria. So this is for the mainstream. This is for your doctor, that your doctors will be looking at when they're considering ME. So it's looking at that massive reduction in activities in daily living. So when you've can't, you've had to reduce how much you're working, you're reducing how much you can do education. So whether that's high school, university, or even continued professional learning. That social isolation of not being able to go to events, not being able to connect with your communities. And then there's that personal, which is your self-care, it is your hygiene. So hygiene, showering becomes exhausting. If you have ME, if you have severe fatigue, please get a shower chair, please. IKEA have some for $45 and they're really cute. Please get a shower chair. You also need to have post-exertional malaise. And then they also want you to have unrefreshing sleep. Again, post-exertional malaise and unrefreshing sleep needs to be from the perspective of a healthy individual versus what you're experiencing. Because you may feel refreshed, but I bet you if you were to compare, if we were able to actually compare to a healthy individual, probably not great. Then you need to also have at least one. So cognitive impairment, which I'm yet to meet someone with ME that doesn't have cognitive impairment. And then orthostatic intolerance, which, heads you into that POTS dysautonomia, standing up and your eyes black out or you're dizzy. So you don't have to have that, but it's, again, one of those really common ones. Okay, how am I going? Is we going okay? Cool. Perrin Technique. So Dr. Raymond Perrin is a doctor of osteopathy. He graduated from the British School of Osteopathy. He is also a neuroscientist and has PhD and has done multiple fellowships and is currently in the US for some research. I say some research like it's nothing. It's amazing. He is actually the same year I was born, started developing the Perrin Technique, which is an approach to treating ME and now long COVID and fibromyalgia. He was the first professional I think it was the 11th of March when the World Health Organization declared a pandemic with COVID. He wrote the first paper that night, turns out it's his wedding anniversary, about basically saying there's going to be long COVID. And I think it was post-COVID-19 syndrome. And then it got changed. So he was the first practitioner or scientist to actually dub that condition and was looking at previous SARS virus and how that looked and going, we're going to see this. And then we have. And then he's had a heap of patients who've come in with long COVID and who they get treated in his UK clinic. This is an evidence-based approach. So the way the evidence has come along is there is research that's specifically done for the Perrin Technique, but there has also been theories and ideas that he has had. And then 5 to 10 years later, science has caught up and been able to prove that for him. So the presence of a lymphatic system for the brain, so detoxing the brain, it's like, yep, that's definitely a thing. I think it was like 7 years later, a neuroscientist did research that proved, and now they call it lymphatics. So quite often he'll have these theories. Another one is around, I'm trying to think the best way to put it so I don't go. So neurotransmitter, so it's how our nerves transmit signals. So that breaks down once it's been used. So one called acetylcholine, it breaks into acetate and then choline. And he's hypothesized that and theorized that there was higher amounts of choline in the body for people with ME. That was later found true. And there is a supplement that's used as part of the Perrin Technique to help mop up excess choline. But the great thing is if you don't have it, it doesn't do any harm. It's just good. It is just a really good omega-3. So this, going back to, it's a very osteo-based approach. It's evidence-based protocol that has treatment as well as homework and some lifestyle modifications. It has a massive focus on the lymphatic system because it's been found that lymphatic system gets a bit bogged up and it's not functioning as it needs to, particularly for the brain. And so it's the treatment is to support that. Lifestyle modifications is a lot around like pacing, and then self-management is helping to support the treatment and also your mobility and movement. I love it. I am self-treating at the moment, although I've had to pause, but I've definitely found some things change. Sometimes worse, sometimes better. But that's quite often you get worse before you get better. So just to like clarify, and just in case anyone's going, what is the lymphatic system? Our lymphatic system is it detoxes us. So it's what takes big molecules that our blood can't be carried in our blood, and it gets sucked into a clear fluid that is then moved around the body. And the aim is to get everything to the liver. So then it can break down the large molecules into smaller ones that the body can use or process. But it will also help to detox through pushing things through our skin, expelling it through urine and bowel movements, and also through our breath, which is really cool. So the highest density of we have lymph nodes all around our body. The highest density is around our mouth and neck because it is trying to protect us from when we're breathing, eating, and drinking. Super cool. And why also so when I started the treatment and self-treating, my face and neck depuffed. It was really bizarre. And I was like, oh, my cheeks aren't quite. And now they're back. They came back. Yeah. So, and then like with the large cells, quite often it's like fat-based vitamins like vitamin A, and then hormones, of course, which we all know women AFAB have lots of. And then in the treatment is recommended to reduce, not cut out, dairy because of the C one. Oh no. No, it's not cow. Oh,
A protein.
it's one of the proteins. It's not whey.
Yeah.
Casein. It's a C one. So casein is a large protein. Sorry. It's a large protein in the milk or in dairy. So reducing casein-rich dairy is recommended. Gluten and sugars, which, yeah, most people have already cut out gluten. It's not recommended to cut them out because we still need to keep a tolerance. But saying that though, I'm not a really rigid practitioner, and I'm not great myself. All right, lymphatics. I'm looking at the time. I think we've got this. Lymphatic. So it's the lymphatic drainage of the brain. So it is taking these cells and toxins, which can be things like heavy metals, excess, like choline, like they found choline in certain parts of the brain. And it's all the byproducts that all of our cells create. So it's taking all those byproducts from, and like basically the garbage, putting it in the cerebrospinal fluid, which is the fluid that helps protect our central nervous system. And so it helps to cushion. It also helps to like cushion our brain, but it is actually along all of our nerves. So it helps to protect our whole nervous system. And then from there, it will then push things into the lymphatic fluids, which is why when we do Perrin, we're looking at bringing things down the neck to where we dump a lot of our lymphatics is through here, our thoracic duct. So we're trying to push down and push up. Fun fact, not so fun, because we have dysfunctional sleep. A lot of people with ME don't get a lot of delta sleep, which is our like really deep sleep, which basically allows our brain to do the garbage pickup and the clean out. So that happens during delta sleep. And so one of the problems is that that's not working. So we end up with like really vivid dreams. You can feel like you have this like boggy head. A really fun, and I wish I had I need to get the magnets to demonstrate, and I might like put a little video up on the Facebook page when I get them. So one of the things that can happen is you can get heavy metal buildup, and technically our body is not magnetic. However, for people with ME and who are quite unwell, they will sometimes find there's these really strong magnets. I can't remember the name of them, but I will post it in the Facebook group when I get them. And they will stick quite often to the back. So thoracics, where there's one of the key findings in ME, because it's just really congested. For people who are really quite unwell, it will stick to their forehead. And in my course, there was another gentleman with ME. It stuck to his back, did not stick to his head, but it did stick to mine. So they were all really excited to see that because, and I was excited. It was really validating. But on the flip side, that you're like, okay, what's in my head? There's lots of questions there, to be honest. So that is the lymphatic. So we're looking at creating that support of getting it to move. And Perrin lymphatics is very different to traditional lymphatics. So we're not just trying to get things to move, we're actually trying to prompt the system to start functioning it on its own, which I really love. And it does start working. I've seen some changes in my patients already, which is really cool. With Perrin, it has its own assessment. And one of the really things that I love is there are physical signs that can be assessed. So if you're not 100% sure and you think you've got PAM, but you're not sure, but we look at your picture and we're like, yeah, it's highly likely. If you come back positive, so some of these do get rated, but if you come back positive for all 5 of these, it's pretty certain that you've got ME. If you come back and you don't have all 5, but the picture is really quite obvious, then we still go ahead with that. So I can't do like a formal diagnosis, but I do like an osteopathic diagnosis. And they're currently working on what recognition we can have in Australia for osteopaths here because we're technically not allowed to diagnose it. So to really quickly go over those 5 points, and it was one of those ones where if I thought about it, I could have gotten you to at least shown you how to do it. But thoracic spine. So quite often we see a flattened spine, which I don't know if you can see, and you've probably seen it in yourself if you have ME, but I don't have much of a curve. It's very flat. And sometimes so much that it'll go actually not just be, it won't be like that. It'll be flat or it might even dip in a little bit. Then, so that's really common. Then we have heat. So if you feel from the shoulder into the middle back between the shoulder blades, there will be a change of temperature and it's usually hotter in the middle. I can afterwards, it's fine. Then we run our fingers along the skin and we do it 3 times really firmly. And to be honest, you can do it anywhere on your body and you'll start getting redness and you might even get a little bit of wheeling and like white and then it goes red and then it stays red for quite a while. It's really prevalent on the back. That is a sign as well. And as well as thoracic pain. So quite often people end up with pain. It might respond to treatment, but then it comes back. So I had this really nervy, jammy pain. Funnily enough, it's gone now after I started treating. But I had osteoana on a regular basis and it just wouldn't go away. And then that's not to say everything is that, but specifically to the thoracics, it may actually be that there is congestion and issues there. So then we have varicose lymphatics, which is like blow your mind, kind of cool, but really you don't want it. So one of the things about lymphatics, so this is going to be a little bit of a side twist, which I might add a slide in to share. Varicose lymphatics is basically where, so with lymphatics, it's meant to have a valve going one way. Then at some point, there's congestion, and then the valve gives up hope, and then it keeps going back the other way. So then you end up with this back and forth, and you end up with these kind of like white little lumps under the skin when it's really severe. But if you feel like quite often, if you feel it, you can actually feel this really light lump, and it's like a line, but it doesn't feel, it's not your muscle. That is a varicose lymphatic, and it's got a cool name that my brain can't remember right now. But the other side that we see it a lot with is stretch marks, which is really highly commonly associated with ME, as well as hypermobility, is basically those connective tissues are giving up. The lymphatics end up getting really like basically almost burst and they get really full. And so we end up with these stretch marks. So interestingly, I've seen it and I've now seen it in patients, like, so with myself is when there was a change in baseline, I ended up with a bunch of stretch marks that I haven't had before. I had some as a teen, but I suddenly had all these and I didn't know where they came from until I did this course and I was like, makes sense. So super cool, really cool to see. I'll share a photo of what really severe ones look like. Then we have celiac plexus, so tenderness in here. If you're pressing in here, you never want to do it with a straight body. You want knees up because it will hurt either way. And then you've also got a craniosacral rhythm distortion. So if anyone's had cranial osteo, you'll have an idea of what that is, but it's basically the flow, the movements of very minor movements of the skull, as well as the flow of cerebrospinal fluid. For the first time, super, super cool for osteos, the craniosacral rhythm was referenced in a medical journal and it was accepted. And that is huge. And it's because they did science and they used physics. And I can't tell you the physics, but it's basically layering the different waves and it was just really cool. So big win for osteos. We don't get a lot of those. Yeah. And then so they're the 5 signs. And so it does involve, same with the treatment protocol, it involves breast work or chest work. So that is something to consider is that comfort level. For me now as a practitioner, it's just become the norm because that's part of the protocol. So, but we always drape, we always are mindful. But that is one where if you're doing the assessment, oh, I forgot one of them. The Perrin's point. This is a really specific one. And I'm gonna, if it's okay with you all, I'm gonna demonstrate it on myself. If you want to try it on yourself, you're welcome to. Is that okay? Yeah. So you want to go to, this is your left side, so your left chest or breast. You want to figure out where your nipple is. You then want to go a little bit to the side and sometimes a little bit up. And it is a point that is really tender, like it will be tender. You're like, and if you go to the opposite side, quite often it's not there. So that is called the Perrin's point. We do score it of like how tender it is. You're like, don't ruin my finger card. So yeah. So that's the 5 ones. But as I said, we do a really, really thorough medical history, lifestyle history from like womb, birth, all the way to current. There's also, which I don't love, but you just have to do them, is some self-reporting. So there's, I think, usually I give 4, and they're done every 3 months as part of the protocol. But they are just like tick boxes. There's no like answer this question in short, you know, you don't have to type things in. It's just rating, which I hate as well, but you know, you just do it. Basically, out of that, we bring a score. So we combine all that, we give you a score. I hate the scoring system, and I say this every time because 0 is death. If you're 0, you're not coming into my room. If you're a 1, you're not coming into my room because you will be housebound, bedridden at 1, and 2, you'll start like that will be really questionable whether you can leave the house. So that is one where I'm working on. I'm going to work on my insurance because I want to be able to do home visits for those people. 10 is healthy. So you're going from 0 to healthy, 10 healthy, and quite often the people I see is around that 3.5, but they're living life like they're a 7. Because type A personality, you're pushing through, you're just doing it, you're wondering why you're crashing and everyone else can live their life. And you've also got kids, or you've got a full-time job, or you've got caring responsibilities. So you can't live your life as a 3.5 because you don't have that choice. Yeah, you can tell this hits home for a lot of people in this room, and you can tell that is my story. So I'm a 3, so borderline 2.5. But I also now worked part-time because something had to give in my life. Yeah, I'm not going to keep going. So that is the assessment and diagnosis. And usually what I will do is communicate if needed to the GP. The protocol itself. So we're coming into the end. Protocol itself is hectic. So it starts with weekly treatments for the first 3 months, and then we reassess. So it is about timing when you can do that. Quite often, and what I'm seeing is there is usually a crash between like a drop and worsening around weeks 2 to 4, and then people start picking up a little bit. Saying that though, when I had to pause, I was really fatigued and had really bad PEM happening. But once I paused it because life events, my baseline came right back up again. So it's one of those ones where some people will fully recover, some will improve, some will be held where they're at, And unfortunately, with any treatment, it can get worse. But we keep an eye on things, and I'm a very cautious practitioner, but like there is another practitioner in Canberra, Kat at Fundamental. I can't speak on how she approaches things, but I'm very, very cautious and conservative. There are some supplements, as I mentioned, that are key. Everything is a discussion and like everything's a discussion. So I have some patients that I've said, can you please talk to your GP or your specialist about these supplements to make sure they're appropriate for you? I've had one that I've said, can you please discuss this with your pharmacist prior so that we're not overlapping or causing any issues? It's not just a you must do everything. It's supposed to be that way, but that's not how I function. As I said, some really basic dietary, the dairy, gluten, and sugar for key reason. But the big one is actually having variety and having a rainbow diet. Like that is the big thing is variety is key. So it's not about what do
I
you
love my beige foods, leave me alone.
Yeah, I know. Me too. But
I know it's not.
you try the best you can. Like, and this is my approach. It's like nothing is perfect, no one's perfect. Everyone tries the best they can. And I've got some patients where the biggest challenge is pacing. But then, so going back, self-massage. So you basically do a version of the treatment, but you do it much lighter. So you don't wipe yourself out. Then there's some mobility and breathing exercises, which I tend to like I'll bring them in at different points because otherwise it's overload and you're asking someone who's already fatigued with a lot going on in their life to do an hour of stuff a night. And that's just not feasible. Contrast bathing, which is my favorite, is using between like a cold pack with a heat pack or a hot water bottle and you're alternating. It is the best. And it actually has helped me with my joint pain in general. So there is a protocol for that. I'm going to put a link up on the Facebook page to the Perrin Technique. All of the self-management home stuff is on there with videos, but the contrast bathing is one I recommend to my regular patients because it is fabulous. Then the other ones, so there's like 4, they have like a little jigsaw corners for Perrin, but pacing, rest, purposeful rest, where you're not actually stressing because you shouldn't be resting, you should be doing your laundry, you should be doing this. It's purposeful rest. Relaxation, however that looks like for you, it needs to be a green light. It needs to be something that replenishes you. And then mindfulness or meditation. I'm hopeless with that one. So very important for ME. Pacing versus graded exercise therapy. So I've had to take a patient off of graded exercise therapy because they were diagnosed with POTS, but PEM and fatigue were their key defining symptoms that was the most impactful in their life. So I had to take them off of that because it wasn't appropriate. And unfortunately, graded exercise therapy has done a lot of people harm in the ME community. It is now acknowledged that it is harmful. So please, if you suspect you have ME, even if you're not getting a diagnosis, please just be mindful of that because they will give it to you for other conditions and you don't want that will potentially lead to a lowered baseline again. But pacing is adjusting. It is supporting those fluctuating symptoms. It's supporting all of those like I have a big weekend, so I then need to back that up with some relaxation or back it up with, that laundry is going to wait 2 days. I've got enough undies. I've like measured it. We're good. There was a comment I'm not going to make. But it is the biggest challenge and it is a really big challenge for parents. It is a challenge for people with partners who have lots of energy and it is a challenge for people who are trying and need to work full time. It's a challenge for everyone, but there are some really key drivers that make pacing really hard. So it is basically the 50% rule at the Perrin, which is look at what you can do without PEM, and then you halve that. If you can comfortably walk half an hour, you turn that into 15 minutes. Now that 15 minutes might be 15 minutes and then 15 minutes again at night but it's about breaking it down. Sometimes it's possible, other times it's not. When it's really not, it's about backing it up with what I call the green light, the traffic light system, or that rest and relaxation. So making sure you are supporting that system and not just go, 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 go. It's hard. It's not easy. Co-occurring conditions, we're coming to the end. So there is a long list there. And I'm assuming everyone will be aware of EDS and POTS. Chiari malformation is a little bit of a saggy brain. It's where a part of the cerebellum, so the little cauliflower bit, actually dips into the hole at the bottom of your skull. I have that. I got diagnosed that when I was 29. I don't know what that is anymore. But it is a common one with EDS, and you can have it without symptoms. So a lot of people have it and not even know, but you can get symptoms as well. Lipedema and lymphedema. So fun thing is you can have all of these things. Lipedema and lymphedema. So lymphedema you can, so with the Perrin we can adjust it to include limbs on the abdomen. We don't generally at the beginning, but like they're classically things you'll see the lymphedema OTs for. But I see a lot of patients with lymphedema and lipedema as well. Long COVID, MCAS, pandas, Lyme disease. So you can have Lyme disease and ME. You can have fibro and ME. Fibromyalgia, I haven't even touched on the fact that ME is quite often being diagnosed as fibromyalgia. It is a very angry sore spot for me. I get very defensive of my patients that have had that happen. Um, and hypermobility is the same thing. So there is a fibro questionnaire. So that is screened as part of Perrin, not to go, you have fibro, you don't have ME, but to make sure we're addressing everything. And like one of the criteria I've found in mainstream that isn't really acknowledged enough and considered is that you actually need to have pain in all four quarters. So if you divide yourself down the middle and then across your ribs, under your, like just above your, like, or around your belly button, you need to have pain in all four for fibro. If you don't, because the fibro points has now been disproven because quite often they're already tender anyway for a lot of people, and quite often practitioners were pressing too hard. And so they're eliciting pain, even if there wasn't really pain, because if you press hard enough, or if someone has lipedema, they will have tenderness around those areas. So it's going to be painful, even if you gently press sometimes. If they're having a flare and they're inflamed, it will be painful. Functional neurological disorder is a massive one. Dr. Perrin spoke about that. Like it can be a bit like ME on roids. It is a really significant version when you look at the symptoms. All right. So that is like a massive, quick info dump on chronic fatigue, ME, and Perrin. There is so much I didn't include because I've already gone for like almost an hour. Are there any questions online, firstly? Pardon?
Yeah.
So what I
Hi, my name is Amy. I have a question.
Yes.
Thank you for that. I stifle off at this because I literally stepped in my POTS assessment yesterday, and newly found out I have POTS. And I just understand that with POTS there can be some fatigue or malaise post-exercise. How does that differ to PEM, or how do you differentiate?
This is the golden question. I guess when I'm considering this is quite often I find with POTS, it's quite immediate because
Mm.
you've had that increased heart rate, that like dysautonomia kind of overload. Or you're trying not to, obviously, but so it's quite an immediate one. And then you
Yeah.
should quite often recover from that. So what I usually say is if you can go to sleep and wake up and feel okay,
Mm.
then that's not really PEM.
Mm.
PEM is where you end up getting this crash. And as I like, it can be over 3 days, but it's not usually like you feel amazing for 3 days and then you crash. It's usually like a progressive, like, oh, my energy's a bit lower. Oh, my sensory stuff's getting a bit worse. Um, it is a really tough one to figure out. And
Mm.
part of it is doing that full assessment and really thorough assessment so that so we're not just so we look at you as a whole, which I know Steph absolutely looks at people as a whole. but we're making sure that we're looking at that and going, well, is that fatigue occurring with like with just like with exercise?
Yeah.
I'm using that.
Or other
Or
stimulants.
is it like, because quite often some of the ones that people don't realize for post-exertional malaise is you you've spent, you spent the day, like you're laying around, you're not doing much, you spent the day watching movies. But it
Mm.
turns out the blue light and the flashing lights and the sound are a sensory overload for your system. And so then you've the next day or the next couple of days, you're like, but I spent all day watching movies. Like, why am I feeling worse?
Mm.
So it's things like that where it kind of doesn't quite make sense.
I'm just going to come around and add my 2 cents as well. My
Please.
other point to that would be also if we are salt loading and things like that, and that's preventing that from happening, then that's a very clear indication it's dysautonomia side of things. Whereas if that's not working, I'd be thinking more post-exertional malaise sort of stuff.
Cool. Thanks so much. I've got some tests to do.
I'm just going
I really struggle to get some of my patients to salt load.
I like my food. If I cook food for anyone else these days, it's probably so salty and I can't even notice.
Fine. Good. It's a really unclear.
No, that helps. So what I'm
What's a
taking
great
away
word?
is if it's a more immediate, like within hours kind of onset that then doesn't last for days, probably more POTS. And if I can do the POTS management and then that helps with the symptoms. Whereas if it's more delayed, if it's not directly related to exercise or that kind of exertion, then perhaps more it's
It
ME.
still can be directly related to exercise. It still can be a lot of that.
Yeah.
It's one of those ones where it can still be both. But
Yeah.
if you're recovering from it and you're going back to you're quite
Right.
you're loading, you're recovering, you can wake up the next day and you feel a bit more refreshed, like you're feeling a bit more refreshed,
Mm.
then it's unlikely to be PEM. Whereas PEM
Yeah.
will and it can be just a sudden crash. It's really
hard to pull apart.
hard to pull apart.
Yeah, I mean everything kind of
And
comes right.
There's so much overlap between so many of the
yeah,
conditions that we all see
Yeah.
together, and even all of the neurodiversity things and all
yeah,
those things will add to those as well. So it is
it's
tricky.
I usually
Yeah, no,
approach
thank you
this
though.
as a case to case. It's a case to case. So I have different
Yeah.
patients that them looks different. And so it really is case to case. And over time, we figure out what that actually looks like for them if they don't already know. But I do have patients with POTS, dysautonomia, and ME. And part of it is they came to me because they had POTS. And then we figured out they have ME. So we're doing all this conservative management for POTS. But I have one where none of the POTS stuff, diagnosed with POTS, none of the solo, none of the actual conservative or medications worked.
Mm.
And so
It's not just that.
it's not, and it's
Yeah.
likely ME with a heart condition, not necessarily POTS. But
Yeah.
we're watching. It's a watch this space.
Yeah.
Yeah. No, thank you. That is really helpful. I appreciate it.
Yeah, and I only recently found out that PEM doesn't have to be from exercise. Because I'm one of those weird long COVID cases that I can still exercise with no problem whatsoever. I do have POTS, and I've been able to manage that with compression and salt and whatever. And so exercise is largely fine, other than when I'm completely flat on my back with fatigue, as I am today, because I increased my work hours from 12 hours a week to 14 hours a week this week just gone.
Wild.
Today I'm feeling it. Yesterday I was kind of okay.
It's
Yeah.
that and the emotional one is even hard,
Yeah.
cognitive, but then the emotional one's massive as well because how do you associate your fatigue that, ending up in bed or having that with, you've had this major thing or there's just even been a shift. So it's a really complex one that so many people, this is where lived experience practitioners are really coming. And I know I'm one and I'm not trying to toot my own horn, but I really appreciate lived experience practitioners because we're living it. And so when we're coming and you're going, so this weird thing happened, and you're like, that's not weird, that makes sense. You see the relief where you're like, because most people walk in going, I'm going to sound so insane, and they're going to try and put some psychological DSM on me. And then you get someone that's like, Oh yeah, that makes sense.
And here are all
And-
the dots connected.
And then here's
Yeah.
the physiological side of it. Like here's what's actually physically happening.
Yeah. I saw a rheumatologist end of last year to get my HEDS diagnosis, and he was like, no, you don't have to convince me that you've got these symptoms. You tell me you've got a symptom and I will believe you. And I'm like, holy shit.
I
I didn't realize how much time I spent convincing people that my symptoms existed in order to then get things diagnosed.
Patients don't. I've had patients lie to me about like smoking, which is one of the really random ones where I'm like, I don't care. I just need to know for risk assessment for certain things. I will give my patients shit. Like I will happily give people, but there is no judgment behind it. And then there is just usually can we reflect a little bit so that we can, support your health in the future.
We also accept shit back too. It's
100%.
It's a very much built rapport.
It's not a one way. I don't berate my patients just for fun. It is like, I had a couple of kids that I treat that they're like 10 years old and they give it back just as well as I give. And their parents love it. So
yeah.
But good on you. Like with PEM, figuring out cognitive, all of those other things, if you figure that out on your own, like kudos. Because it's really hard to connect those dots on your own.
I was going to say, anyone that I've spoken to that will know that I've talked about the fact that I'm collecting the whole bingo card, and ME/CFS is the only one I have no signs of. Turns out I lied. So that's a really fun discovery for me today. So if anyone else has any other questions, feel free to jump in. But otherwise, thank you so much for coming to talk and share your passion about everything ME/CFS related.
And just on a little end, in the slide pack, there is my email address, my website. That is also my Instagram that I literally have 0 posts on. So just giving you a heads up, I use it to follow dogs. I will start posting at some stage.
Yeah, me too.
And then there's just a little thank you, a big thank you for listening to me ramble. So I have the textbook, I use that a lot. One thing I didn't actually, I'm just going to flick back to co-occurring, sorry, is there is a term that is now, there's an initiative to push towards a term called infection-associated chronic conditions. There is a website. It is actually really cool because it doesn't mean that we don't diagnose and look at it, but we start looking at it as a whole picture rather than these individual diagnoses and how they work together. And that, and also that if you're diagnosed with POTS, we need to look at other things, where in the mainstream medical world, it's still quite isolated. So hopefully with that push, we start getting more of that like overall encompassing care happening.
One day, hopefully.
But there are websites, and you are very welcome to email me any and all questions. I'm a very open practitioner. There is no phone number because I lost my work phone 2 months ago. But if you don't feel comfortable contacting me, feel free to contact. Oh, there's chats. Whoops, sorry. Got to run. Ouch. Oh yeah, cool. But thank you so much for having me. And I'm sure you'll probably see me again at some stage for whatever reason.
Yeah.
Yeah. Cool. Thanks.